Hello, my name is Dr. James Gill and you've joined me for another clinical skills video. Today we're going to be focusing on the respiratory exam, both demonstrating the exam and going through each bit and highlighting what it is we're looking for and how we're doing the examination. So, with that in mind, we'll get started. In order to start off our examination, obviously we want to make sure we've gelled our hands and we introduce ourselves to the patient. Hello, my name is Dr. Gill. I've been asked to do an examination of your chest today, so specifically your lungs. That's going to involve us having a look at you as you lie there, getting to take your shirt off, checking your blood pressure, having a look over your hands, your face, putting my hands on your chest and listening with a stethoscope. Is that okay? Mm-hmm. So before we go any further, could we please confirm your name and date of birth?
It's Elvis Alvey, 2nd of January 2000.
Super. And do you have any problems with your chest at the moment?
No.
Super. And any problems with your breathing?
No.
Brilliant. So we're just going to start off and as I'm looking at the patient, in that initial step, I'm just making sure that he seems calm, at rest, and I'm looking around the bed. So I can't see any sputum pots, nebulizers, anything that might suggest that there's any respiratory issues going on underneath. And similarly, as the patient's lying there, I'm looking at the rise and fall of his chest, making sure that I can see that he doesn't appear to be in any obvious respiratory distress. And I can check that at this stage. Could you just take a nice deep breath in for me? And out. Any issues with that?
No.
Super. So what we're going to do, I'm going to sort out your blood pressure and things. So if I could get you to take your shirt off, please. So it's very important that we're going to be able to use the manual blood pressure cuff, but we're also going to, as well as taking his pulse manually, we will want to use a pulse oximeter to make sure that we can determine his oxygen saturations, i.e. how much oxygen is going from his mouth all the way to his fingertips. So just have a finger to start off, please. Okay, and we'll just put that and relax that down there. And these normally take a couple of seconds to work. If somebody has a cold fingers, for example, maybe Raynaud's, or they've been outside before coming to clinic, we may have a problem. And here we're showing us an oxygen saturation of 98%, so we know that's absolutely fine. And then we need to have a look at his hands. So if you could put your hands out for me. And we're looking to see if there's any evidence of a fine tremor that we might associate with salbutamol use. Thankfully, there's no evidence here. So what we're going to do is we're going to take a piece of paper, we're going to put that over the fingers, and again we can see no tremor being exacerbated with the paper, so we know we don't have a fine tremor. And if you could just cock your wrist back, please. Okay. And we can see no evidence of a flap here that we might associate with CO2 retention. So having a good look over the fingertips, we can't see any colonychia that might indicate iron deficiency anemia. We can't see any evidence of yellow nails, and there doesn't appear to be any signs of clubbing. Any blue tinge to the fingertips, which might indicate cyanosis, and similarly if there's any tar staining that might indicate a patient smokes. If you could turn your hands over, please. And we're going to press over the fingertip, looking at the capillary refill, and it should ideally be less than 2 seconds. If we had issues with Raynaud's, that could be one of the reasons that would slow the capillary refill there. We're also going to look on the palmar creases to make sure there's no evidence of anemia, are nice and pink and healthy, so again no signs of anemia, and I'm making sure there's no wasting of the small muscles of the hand that might relate to potentially a Panco's tumour pressing on the nerves there. Now if you could turn your hands back over and put your fingers together like so. So there didn't appear to be any signs of clubbing, but we're looking and we can see Shamroth's window, so we now know there's no signs of clubbing. Relax down for me. So having got our vitals in place, if there was a concern, we may also do a temperature at this stage, but we're not going to worry about that. Now I can use the 62 beats per minute that we've got on there, but we also want to be able to take a manual pulse, so we're going to press over the radial border of the arm, and I'm just checking and feeling that pulse there. Again, In an OSCE situation, I'd count for 15 seconds and multiply by 4. The other benefit of checking here is that I can confirm the rhythm as well as the rate. And I'm going to move up a little bit higher onto the arm to press over medial to the bicep tendon to feel the character of the pulse. So is it thin and thready, or is it full and bounding? So with no obvious issues there, we're going to check the patient's blood pressure. So any issues with that arm at all? One of the things that you can encounter sometimes when we ask about blood pressure is maybe somebody has had, for example, breast cancer and they've had an axillary clearance, so problems on that arm. Similarly, a patient may have had a renal fistula foot in, so we'd want to protect that arm. But there's no issues here, so we're going to go forwards. I'm going to check the index of the arm, make sure it's covering the right size. So we've got the right size cuff. And then bring things up and round. And the first time, obviously, we're going to make sure that I'm checking his pulse and feeling for it to disappear. Okay, so the pulse is gone. And then letting the pressure out. And that's returning at about 90 systolic. Okay, so that's interesting. So I'm going to do the same again, but this time listening with the stethoscope, and I'm going to increase the pressure by 30 millimeters to make sure I've got the right location. And I'm going to be listening for the pulse to disappear and then reappear. So tightening up. Okay, so at full pressure, the pulse has disappeared and coming back down. Okay, and the pulse has reappeared at 102. Okay, and we've got silence again at 70. So 102 over 70, that's a nice, healthy pulse. Now, having completed our vitals, we can again have a look at the patient without his shirt on, and we can't see any abnormal signs of respiration. So there's no obvious asymmetries to the chest, there's no clear scars. We must make sure that we also look at the patient's back, because if, for example, you've had a lobe removed, then we'd see the scar at the back rather than the front. I like to do my examinations up in a straight line and down because, well, I'm a bear of a very small brain, and if I'm following a simple line, I can't have forgotten something. So we're going all the way up to the top of the head, and if you could take your glasses off, please. And if you just pull your eyelids down, and I'm having a look to see, and I can't see any signs of anemia. And relax. Now, some texts will suggest that you should also pull the eyelids up to have a look at the white of the eye to see if there's any evidence of jaundice. Now, to my thinking, jaundice is mainly an abdominal system sign. However, there's no such thing in medicine as never, so we can theorise ways that we could be wanting to check for jaundice in a respiratory patient. If, for example, there was a hemolytic anemia where the blood cells were being broken down, that high turnover of blood could result in a raised bilirubin level in the system, which could give rise to anemia and thus the patient being short of breath due to sufficient blood to carry the oxygen around. So that could be one rationale for doing it. We're then going to have a look down at the patient's mouth. So if I could have a look at your tongue, please. Okay, so we've got good hydration status and it's not large and smooth, suggesting a B12 deficiency, nor is it pale and anemic. If you could put your tongue to the roof of your mouth, please. And here I'm having a look at the base, thank you, and there's no signs of central cyanosis. Similarly, I can't see any blueness around the lips, so I'm very confident that there's no cyanosis here. Cyanosis is a particular sign. You're only going to have that when you've got 10 decilitres per mil of deoxygenated hemoglobin. So we can get the peripheral cyanosis, where we may have blue fingertips if we've got Raynaud's, if we've got exposure to cold and we're at altitude, because literally the blood supply is stopped to the fingers, so the tissues there have pulled the oxygen from the blood, causing an increased level of deoxygenated hemoglobin. However, if we've got a respiratory or potentially cardiac issue, then we're going to get the central cyanosis if there are issues with oxygenation. If, for example, you've got a ventilation-perfusion mismatch that you might see with a pulmonary embolism, where the blood vessels in the lungs have been blocked. So although the lung seems to be working, i.e. you can breathe into it, that part of the lung is not being able to transmit the oxygen to the blood. So you end up getting some deoxygenated blood coming back into the system. Hence, it builds up and we get that blue appearance. One of the other things we need to pay attention for when we're doing a respiratory exam and looking at the face is evidence of Horner syndrome, which may occur due to a Panco's tumour, so in the apices of the lung pressing on the thoracic chain. So with that, we're having a look in the eyes themselves to make sure that we haven't got miosis, a small pupil. There's no sign of ptosis, so his eyelids are equal the same. And there's no evidence of something called anhidrosis, the lack of sweating on one side, the affected side of the face. Now, the first two, the ptosis and meiosis, are very easy to assess. The anhidrosis is less so. However, the patient may mention that in their history taken beforehand. Carrying on down the body, we then need to have a look at the trachea. So to start off with, we need to find out if the trachea is central. So after we've had a look over the face, we need to put a small amount of pressure on the neck. But before we do that, we need to make sure there's no problems. Do you have any pain at all around your neck?
No.
So it's important we check that with regard to things like thyroiditis and recent surgery and things. So we're going to feel down the sternocleidomastoid muscles between the head of the clavicles with a tiny bit of pressure, and I should be able to feel the pressure between my fingers, showing that trachea is central. If we had a pneumothorax, it would push the trachea one way, and conversely, if there was a collapse, it would pull the trachea toward it. Now, did that hurt at all, or cause you any discomfort? So it's very important about the pressure that we're applying there. You can try this on yourself at home. If you get two fingers and just shove it at the base of your neck, it's not a particularly pleasant thing to do. So A, it can be beneficial if you're new to this, warn the patient what you're about to do and how that they might perceive it. But also, by practicing on yourself, you can modulate the pressure that you're going to need to be able to apply so that you can determine you've got the right pressure to get the information you need, but not hurting the patient. So we then need to check around your neck for any lumps and bumps. Could I get you to sit up and swing your legs round? We're going to examine the lymph nodes from behind, so that's going to mean me putting my hands on your neck. Is that okay?
Yep.
This is something I'm particularly keen on making sure the patient is aware of and is comfortable with, because otherwise you go to examine the lymph nodes and suddenly hands appear from behind, which can be startling and potentially unpleasant for many patients. So we're going to start off under the chin, checking the submental lymph nodes, and then along the angle of the jaw, the submandibular, to the base of the angle of the jaw, to checking the tonsillar, and slightly above that, the parotid lymph nodes. We're going to do all the head and neck lymph nodes, so checking for the preauricular and the postauricular, and then at the back of the head, checking for any occipital nodes. We want to press down the neck, checking for the deep and superficial cervical chains, sometimes referred to as the anterior and posterior cervical chains. We also want to check along the clavicle, and for a respiratory examination, get the patient to shrug their shoulders up and forwards. That lets me push down on the left side in the supraclavicular fossa here to make sure there's no evidence of a Panco's tumour that's suggesting that we've got an apical lung tumour here. So if you relax back for me. Okay, so in terms of having a look at the JVP, we get the patient to lie back, and if you could turn all the way to the left for me, and just relax. So we're waiting for the sternocleidomastoids to go completely relaxed. And we're having a look to see if we can see the JVP, and there's a pulsation here. but we can also see a slight pulsation here. So I'm going to press over here, okay, and I can feel that, suggesting that's the carotid. And over here I can't feel this pulsation, so we know we've got the JVP. In order to confirm that this is a JVP, we're going to do the hepatojugular reflux. So I'm going to press down on the abdomen. Okay, so do you have any pain over your stomach?
No.
Okay, so I'm going to look over here. I'm going to do 1, 2, 3, up and in. I'm going to press in deeply. 1, 2, 3. Okay. And we saw that rise occurring there. So we know that what we're looking at is the JVP and we're in the right location. We'll also confirm the height of the JVP because we're going to measure an imaginary ruler up 3 to 4 centimetres here and then pull across. And as long as this is below that 3 to 4 centimetres, we know that everything is healthy. We may get a JVP that's risen so far up we can't actually see it, in which case it's gone up inside the skull. But we may expect that in somebody with hyperinflation, for example, COPD. Now, we've already had him do one deep inspiration and observed no obvious issues, but we're going to do that same again now. So if you can take a deep breath in for me, and out. The movement again appears normal, and I can't see any obvious changes to the chest here. So we might be looking for things like pectus excavatum, where we've got a deep sulcus between the ribs. That will be a congenital deformity. Conversely, we may have a pectus carinatum where the ribs are pointing forwards, which could have issues in terms of pressing on internal structures. Now, whilst the movement of the chest appeared to be normal, I want to double check that, and I'm going to do that by putting my hands on the chest. We're resting our palms on the chest. Deep breath in and out. And I can see my thumbs moving apart. We then need to do the same lower down as well. Deep breath in and out. So I'm looking at the movement of my hands because it's going to be different potentially for different individuals, and things such as a barrel chest that you may see with COPD, where the chest is hyperinflated, you may get a different level of movement compared to somebody like Atharva here, who doesn't have any respiratory problems. So what you're looking for is to make sure the movement is equal on both sides. So having checked for chest expansion, we then need to assess where his apex beat is. So that's the area of the heart most lateral, where often you can see, certainly in thin people, the apex of the heart hitting against the chest wall. Obviously we can't see that here, so we need to prove where the apex beat is. So we're going to find the maneuverable sternal angle, which is in line with the second intercostal space, and then we're going to count down. 3rd, 4th, 5th, and we're going to measure round, so we're in the mid-clavicular line, and I can feel the apex beat just about here. Now, if we had somewhere where we couldn't feel it, we get the patient to roll over onto their right and keep holding there. And come backwards for me. If we've got a patient perhaps with COPD and we've got hyperinflated lungs, we may not be able to feel the apex beat due to that lung expansion, particularly with the lobe over the heart there. Conversely, we may have a patient that has heart failure and they've got a left ventricular hypertrophy as a result. This can result again in movement of the apex beat and perhaps a diffuse or tapping apex beat. Another area where cardiovascular is going to cross over with respiratory, we need to feel for a heave. So sometimes there's a debate as to whether or not we assess for both heaves and thrills. I would argue that the heave is the important part in a respiratory examination because that is feeling for a left ventricular hypertrophy. Conversely, the thrill is a palpable murmur, so I would argue is firmly in the cardiovascular side of things. But with regard to a heave, we're going to place our hand over the left side of the chest and lock out our arm. If we did have a left ventricular hypertrophy, we'd feel the whole of our arm pushing off the chest. So, having palpated across the chest, we then need to percuss the chest. So we're going to start off by placing a hand flat above the clavicle, and I'm going to percuss on the distal interphalangeal joint. In terms of percussion, we're going to percuss over the apex and then also over the clavicle. We're then going to continue down. After covering the anterior of the chest, we must also go around to percuss over the axilla. And any changes in that percussion note we're going to highlight because we're going to need to focus on that area when we get our stethoscope out. When it comes to percussion, we may get hyperresonance, so sounding like we're beating a drum practically, if we're looking at a pneumothorax. Whether or not that's a tension pneumothorax or merely a collapsed lung, we wouldn't be able to tell from the percussion note. But we would have other information that would suggest one or the other. A tension pneumothorax may result in an imbalance in the chest expansion when breathing, and similarly may push the trachea away from the side that is affected. If we had a collapsed lung, then we'd find a decreased percussion note over the area of collapse. Similarly, consolidation from an infection or pneumonia, or potentially pleural plaques, if being exposed to asbestos, would also potentially have a decreased percussion note. We then want to take our stethoscope and we're going to listen over to all the areas that we've just percussed. We're going to ask the patient to take a deep breath in and out through the mouth as we do so. So deep breath in and out. 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 So apart from over the clavicle, where we do percuss, but we do not auscultate, we're going to listen over to those same locations. And with that, I got normal vesicular breath sounds throughout. When it comes to breath sounds, there are three major sounds that we need to pay attention to. So bronchial breathing, which you can listen to at home by listening directly over your trachea. So that's a very hollow whooshing noise that, if heard lower down in the lungs, we would associate with a potential of infections or consolidation. We'd also want to be paying attention for wheezing. This is a whistling sound heard on expiration and is associated with the small airway narrowings often seen in asthma, but again can be seen in infections. There is a counter to a wheeze, which is a stridor. Now, a stridor is a medical emergency, whereas a wheeze is an inspiratory sound due to narrowing of the small airways. A stridor is an expiratory sound due to narrowing of the large airways. So that could be potentially due to a tumour blocking the bronchus or pressing on the trachea, or potentially in the case of a child having swallowed a foreign body. If you remember nothing else from this video, that is the key take home. A wheeze we need to address, but a stridor is an emergency. The other sound that we can listen to, or listen for perhaps, is a pleural rub. This is often described slightly conflictingly, either as the crunching noise that you get when standing on fresh snow, with that little squeak as well, or sometimes like the squeak of rubbing sandpaper together. But I assure you, once you've heard a pleural rub yourself, you'll never be able to walk on fresh snow again without stopping and hearing that as you step on that fresh snow. So having completed the examination on the front, we then need to get the patient to sit up. And this gives us an opportunity to assess the chest from behind. So again, there's no signs of scars and no obvious scoliosis or deformity. Now with regard to scars, if you recall previously, we highlighted that any sort of pneumonectomy, any removal of lobes, the scar is visible on the back rather than the front. We also then want to do chest expansion at the top, deep breath in and out, and then again right at the bottom, in and out. So we've got good chest expansion there. We then need to percuss over the chest. I'm going to get the patient to cross their arms over the chest, please. And this opens up a lovely area between the spine and the scapula. And I'm going to percuss down between the spine and the scapula, which have now just moved apart. So we've got normal percussion throughout, and then we're going to auscultate. And we're going to do the same as we did on the front, and auscultate over the areas we've just percussed. So if you breathe in and out through the mouth, please, and out. In 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 and out. We then need to press over the sacral region, make sure there's no signs of fluid there. And during the auscultation, we auscultate all the way down to below the 12th rib, whereupon we'd lose the normal breath sounds. Now, before we put the stethoscope down, we also need to listen for vocal resonance. So what we're doing here is we're listening for the transmission of sound through the lung parenchyma. Now, if we think about whales, I know we're jumping around suddenly, but whales can have their whale song travel for miles and miles under the water, because water is a very good conductive medium. However, their sound obviously doesn't travel above the water because air is an insulator. It's the same reason why if you put your hand in water at 50, 60 degrees, it's going to scald you, but there's no problem with putting your hands into an oven at 100 degrees in order to put something into the oven that you're going to cook. So what we're going to do, we're going to get the patient to say 1, 1, 1, and we're going to listen for the sound transmission. Now, the individual who came up with vocal resonance was German, and thereupon he asked his subjects to say 99. Well, actually he didn't. He asked them to say 9 or 90, which is a diphthong. So the reason why that's important is a diphthong has a different sound wave, so travels through fluid and tissue differently to 99, which is not. So we need to use another diphthong ourselves, whereupon we're going to get the patient to say 1, 1, 1. And if we're listening of a normal lung, we should find a muffled sound coming through. Conversely, if there was consolidation, for example a collapse, if there was a pleural effusion, or if there was an infection and consolidation, we get a very clear transmission of the sound. So, listening over the chest. So if you could say 1, 1, 1.
1, 1, 1.
And again.
1, 1, 1.
And again.
1, 1, 1.
And again.
1, 1, 1.
Final 2.
1, 1, 1.
And again.
1, 1, 1.
Okay, that's fine. So we've got normal vocal resonance there. If you could step backwards for me. So we can listen over fewer areas with vocal resonance because of the nature of sound transmission, given that it's coming from the voice box. So the last bit of our examination will be to have a look at the patient's legs. So finding the medial malleolus and going up, We're pressing with 10 millimetres of mercury so our fingertips go white and waiting for 10 seconds. And then running our finger over to make sure we can't feel any indents of edema. If there was edema, it would have been forced out and we would have been able to feel it. We must make sure that we're pressing over both sides. I'm going to do the same again, getting our fingers white, and then we're going to wait for 10 seconds. And then again running back over to confirm there's no problems. So we've got a normal examination there, we haven't found any issues. Do you have any questions for myself?
No.
Super, we can get you showed, thank you.
Thanks.
To complete our respiratory examination, we'd also assess for any sputum cultures that have been sent to the lab. We'd want to review any chest x-rays, perhaps do spirometry or a peak flow meter, and also look at any arterial blood gases that may or may not have already been done. So that completes our overview and in-depth rundown about how we do the respiratory examination. I hope this has been useful for yourself. Please put down in the comments what other systems you'd like us to do a breakdown like this for. If I could ask a favour of yourselves, if you could like the video, it tells YouTube we're here. And if you click the subscribe button, it lets you get involved with us on the community tab so you can help us guide where the videos are going next. With that in mind, thank you very much, and we'll see you in the next one. Cheerio.